My name is Adam Burgoyne. I am a medical oncologist at the University of California in San Diego, where I co-lead our multidisciplinary HCC clinic.
Hi, I'm Stacy Stein, and I'm a GI medical oncologist with a focus in hepatobiliary cancers at Yale University and the Smilow Cancer Center.
Hi, I'm Megan Grant. I'm a nurse care coordinator with the San Diego VA Medical Center. I help to coordinate care with our liver tumor board and our GI hepatology clinic.
Hi, I'm Isabel Newton. I'm an interventional radiologist at UCSD and at the VA in San Diego.
Hi, I'm Anjana Pillai. I'm a transplant hepatologist at the University of Chicago.
Hi, my name is Amit Singhal. I'm a transplant hepatologist at UT Southwestern Medical Center in Dallas and serve as the medical director of our liver tumor program and chief of hepatology.
Hello, we'll be discussing emerging evidence on immunotherapy in early stage HCC. The learning objectives for emerging evidence on the role of immunotherapy in early-stage HCC describe the results of key clinical trials investigating novel immunotherapy approaches for early-stage HCC, formulate a plan that considers patient-reported outcomes such as physical functioning, symptom burden, psychological well-being, and social functioning. For our patient case scenario of Mr. Jones is a 54-year-old male undergoing surveillance post-SVR. He's found to have early-stage HCC, unifocal with max diameter of 3.6 centimeters, Lirads 5 on imaging. He has compensated cirrhosis with no portal hypertension. He's child PUA with a bilirubin of 0.7, albumin of 4, INR of 1. Platelet count is 110. His AFP is 42. He also has good performance status with an ECOG of 0.
So, I think what we've seen from our patient case, the good news is that the patient was undergoing HCC surveillance and was found at an early stage. And I think that this case highlights the benefits of HCC surveillance. When we take a look at the literature, we can see from this systematic review and meta-analysis that HCC surveillance is associated with many clinical benefits, including significantly higher early-stage tumor detection with an odds ratio of approximately 1.9, increased receipt of curative therapy with an odds ratio of 1.8, and improved overall survival with a hazard ratio of 0.67. Unfortunately, we do find that despite these proven benefits, HCC surveillance is often underused in clinical practice. And current data suggests that adherence to current surveillance recommendations is unfortunately below 25%, which explains why we see so many patients that are detected beyond an early stage. When one considers the surveillance recommendations, surveillance is typically performed using the combination of an abdominal ultrasound combined with a serum biomarker alpha-fetoprotein, and these tests are performed every 6 months. The routine use of dynamic contrast-enhanced CT or MRI is not recommended, and these are really restricted primarily to patients in whom ultrasound and AFP are not thought to work well, including patients with severe visualization limitations on ultrasound. When one takes a look at the at-risk population, the high-risk patients for the development of HCC are primarily patients with cirrhosis from any etiology, and this accounts for over 80% of HCC in the Western world. When one takes a look globally, it's also important to consider patients with non-cirrhotic chronic hepatitis B, and we can see several high-risk subgroups that are outlined on the slide here in whom HCC surveillance is recommended.
So the treatment recommendations for a patient with hepatocellular carcinoma, according to the 2022 Barcelona Clinic Liver Cancer Guidelines, are as follows, and this is really just a guideline. Each multidisciplinary team will use this and apply this in a different way according to the resources available and local preferences and areas of expertise. But our patient falls in the BCLC 0 or A early stage category, and these are the patients that really have a plethora of opportunities for treatment. These are the ones that we try to treat with curative intent. And so they're the ones with a single nodule that is less than or equal to 3 centimeters or less than or equal to 3 total nodules and preserve liver function. And for these patients, we offer resection, so taking the tumor out, liver transplantation, so replacing the entire liver, ablation, which is the local destruction of the tumor tissue percutaneously usually, but you can also do it laparoscopically, or some of our liver-directed therapies such as transarterial chemoembolization or bland embolization or transarterial radioembolization. And the reason why these last ones are on the list is because some patients, even if they are candidates for curative intent treatments, like the first three, may not prefer to undergo those treatments, and so these other options do remain open to them.
When you're considering potentially curative therapies for early stage HCC, you have to consider the different options that are available. And so ablation, under that umbrella, there are various kinds. The very earliest type of ablation was ethanol ablation. That's hard to control. Then came cryoablation, which is the use of lethal ice to destroy tissues. But more commonly these days, we use microwave energy to use heat to destroy tissues. Before that was radio frequency. It's still being used in some institutions. But all of these are almost like a bomb. They destroy the tissue within a radius of the probe and indiscriminately, and can be done under either CT or ultrasound guidance, typically more and more ultrasound guidance. The value of ablation is that many more patients are amenable or are able to undergo ablation, even if they are not surgical candidates. But we try to get as many patients to surgery as possible, and surgery can either look like resection, which can be done in class A cirrhotics and has limited use in portal hypertension, and that varies from institution to institution, depending on how comfortable the surgeons are with operating in patients with different levels of portal hypertension. And in some cases, it can be done laparoscopically if there's a unifocal BCLC stage A tumor with just mild portal hypertension. Transplant is kind of the idea of, hitting the reset button and has the best opportunity for overall survival in these patients, but they must meet criteria. And so that is regionally defined, and different criteria are used depending on where you are in the United States. So because of this, there are very few patients who actually make it to liver transplant, not just because of liver availability, but also because of candidacy on the part of the patient.
When we're further defining transplant criteria, we will start with the Milan criteria, which was initially defined in a landmark article by Dr. Mazzaferro in 1996, which is a single tumor less than 5 centimeters or multiple tumor, but no more than 3 tumors, and each being 3 centimeters or less. However, subsequently, multiple other criteria have been used to transplant patients, but within the United States, the UNOS, or the United Network for Organ Sharing, uses Milan criteria as acceptable criteria for transplant. As far as downstaging, or the ability for patients that are outside of criteria to reduce tumor burden to get within, Milan criteria, this also has specific size and number, including 1 lesion greater than 5 centimeters or up to 8 centimeters, or 2 to 3 lesions with at least 1 lesion less than 3 centimeters to less than 5 centimeters, the total diameter no more than 8 centimeters, or 4 to 5 lesions, each less than 3 centimeters, again with a total diameter of less than or equal to 8 centimeters. This downstaging criteria was incorporated into listing criteria in 2018. Most patients who receive potentially curative therapies, that is ablation, resection, or transplantation, have a median survival duration of greater than 60 months. However, it is important to note that HCC can recur in as many as 50 to 88% of patients that undergo resection or ablation, which is because the underlying liver, which is cirrhotic, remains, as opposed to those who undergo transplant, where the recurrence rate may be as low as 10 to 15% in those that are within Milan criteria. As far as other research, both adjuvant and neoadjuvant immunotherapy have been evaluated for patients with HCC after resection or ablation.
Based on the recurrence risk from early therapies, there's a lot of interest in applying systemic therapy in the adjuvant setting. The IMbrave 050 study looked at the role of atezolizumab and bevacizumab versus active surveillance in the adjuvant setting. These were for patients who had undergone curative resection or ablation with well-preserved liver function and were thought to have a high risk of recurrence based on high-risk features including a tumor greater than 5 centimeters, greater than 3 tumors, microvascular invasion, minor macrovascular invasion, or grade 3 or 4 pathology. Patients received either the combination of atezolizumab and bevacizumab or surveillance for up to a year, and the primary endpoint of the study was recurrence-free survival. The study did meet its primary endpoint, and you could see at 12 months the recurrence-free survival was 78% versus 65%. However, as time goes on and the patients are off drug, the curves come together. And so there is a difference in recurrence-free survival at 1 year. However, it is not clear what the impact is of a year of treatment for these high-risk patients and balancing that with the risk of treatment. The adverse events on the study were largely manageable. There were grade 3 or 4 treatment-related adverse events in about a third of the patients, with serious adverse events of 10% in the control arm and 24% in the treatment arm. Because of this interest, there are several other phase 3 studies evaluating immunotherapy in the adjuvant setting. The first one here is the IMbrave 050 study, but there are also studies looking at pembrolizumab versus placebo, nivolumab versus placebo, durvalumab with or without bevacizumab, or toripalimab. And I think it will be important to see the benefits of each of these regimens and be able to come up with a more definitive conclusion about the use of adjuvant immunotherapy in this setting.
Circling back to our case study, Mr. Jones. He is the 54-year-old male post-SVR found to have a 3.6 centimeter HCC. Based on imaging and labs in his workup, he has compensated cirrhosis with no portal hypertension. Ultimately, patient underwent robotic resection without complication. He was then discharged home 3 days later. Upon discharge, it's important to ensure that he has appropriate follow-up with the outpatient specialty clinics.
So I think in this setting, it's important to think about, who should be following with the patient and if we should be having a discussion with all of the patients post-resection about the use of immunotherapy. Right now we have the IMbrave 050 data, while there are other ongoing phase 3 studies. I think it's important to have a discussion with each patient and really think about the risk and benefit and the data from the study. It is not standard of care to offer this to patients, but on a case-by-case basis, there might be some cases where the patient and their team may decide to use immunotherapy. It doesn't seem from this case that there were any high-risk features, but I think that's why the discussion is important. Dr. Singhal, do you have other thoughts about the use of immunotherapy in this setting?
Yeah, thanks, Dr. Stein. I completely agree with you that I think that, of course, having a good discussion with your patient regarding the data and the risk-benefit ratio of immunotherapy in the adjuvant setting is important. But I think the interpretation from our clinical setting is that right now these curves appear to separate early, but then they converge later on. And so the long-term benefit of using immunotherapy in this setting is currently unknown and arguably questionable. And so, the idea of using adjuvant therapy is really to prevent recurrence, not simply delay it. And from the current data, it's unclear if that's happening. And so our current practice is not to use this routinely. And, really it would take someone with very high risk features for us to use it at this time. So I think there's a lot of excitement, as you mentioned, about perioperative treatment and maybe considering even neoadjuvant trials in the future. But I think as of today, we don't routinely use adjuvant therapy and would not offer it to this patient. So I think this was a great discussion of, the emerging role of immunotherapy in early stage HCC. I think there are several key takeaways that we hope, the listeners learned today. The first is that surveillance is important. Surveillance in at-risk patients is associated with improved early detection, increased curative treatment receipt, and improvements in overall survival. And, as we discussed, this is underused in patients. And so really it's important for us to think through interventions to improve surveillance receipt so we can improve early detection and curative therapies. When patients are found at an early stage, these patients are amenable to curative therapies, and it's important that they are referred into multidisciplinary programs to consider therapies such as ablation, surgical resection, and liver transplantation. We didn't go through this in detail today, but we know that these therapies are underused even in patients that are found at an early stage. And so it's important that we try to do these curative therapies if and when possible. And finally, as we just discussed, there's a lot of excitement around immunotherapy in the perioperative setting. Although right now the benefit of immunotherapy in this setting is the subject of ongoing research, and I think, as you heard, is not routinely used at this time. Finally, I think the one thing that I'd say is, given the excitement, if and when your patient is eligible for a clinical trial evaluating either neoadjuvant or adjuvant therapy, these patients should be referred for clinical trials given the excitement for immunotherapy in this setting moving forward.
Hello. Today we'll be discussing emerging evidence on immunotherapy in intermediate stage hepatocellular carcinoma. Our learning objectives for today will be to describe the results of key clinical trials investigating novel immunotherapy approaches for intermediate stage HCC, and formulate a plan that considers patient-reported outcomes such as physical functioning, symptom burden, psychological well-being, and social functioning. Our case study will be for Ms. Rhodes. She's a 53-year-old female with a history of obesity, controlled hypertension, treated dyslipidemia, and prediabetes. She presents to the ED with severe right upper quadrant abdominal pain. She's had mild discomfort for several years, but notes worsening of pain over the past 2 to 3 months. She has no history of hepatitis infection or alcohol use disorder. Imaging obtained in the ED and following admission includes an abdominal ultrasound showing an enlarged liver. A CT of the abdomen with contrast shows a suspicious discrete mass in the right lobe of the liver. And ultimately, a liver MRI shows an 11-centimeter mass predominantly in the right lobe. Biopsy confirmed metabolic dysfunction-associated fatty liver disease without cirrhosis, Child-Pugh A with good functional status. Her MRI shows a Leyrat's 5 mass consistent with diagnosis of HCC, and we will be considering what treatment options to recommend.
Clinically, we use something called the BCLC staging system, which was recently updated to include more of the treatment options that we have available to us today. So this divides hepatocellular carcinoma into very early stage, intermediate stage, advanced stage, and terminal stage. And today we're focusing on intermediate stage. And for this, the predominant therapies are catheter-directed therapies within the local regional therapy kind of umbrella. About 30% of patients are in intermediate stage at diagnosis, and BCLC recommends TACE predominantly for these patients. However, this new updated BCLC system has a clinical decision-making portion, which acknowledges the fact that although the mainstay for intermediate stage HCC is TACE in most places, we are finding that, and this reflects that for many of these patients, radioembolization may be a more attractive option. And for those patients who are not amenable to either TACE or TARE or have had a failure of these, immunotherapy may offer a viable option. So the local regional therapies that are available for the management of hepatocellular carcinoma are ablation, which is a potentially curative therapy that destroys tissue in situ. And this is not typically used for intermediate stage HCC because there are not discrete tumors of a size that can be completely eradicated with ablation. Typically, once you get to intermediate stage, there's more disease that is beyond what you can just destroy focally with ablation. And so we use transcatheter therapies. And those can be divided into TAE, or transarterial embolization, where you have little beads that are bland beads. They don't have anything conjugated on them, and they just block the blood vessels. Transarterial chemoembolization, where those beads are soaked in chemotherapy poison and therefore elute this chemotherapy over weeks to months and also block the blood vessels. So pack a 1-2 punch against the tumor. And radioembolization, where those beads are soaked in Y90 or yttrium-90 radiation. You'll see there also drug-eluting bead chemoembolization is just a variation of TACE. Finally, there is stereotactic radiotherapy, where there's you can also consider it as external beam radiation. So in contradistinction with radioembolization, where the radiation comes from within the tumor, this is from outside in. The way that liver cancer interacts with the immune system provides opportunities for targeted treatment. For example, a lot of the local regional therapies that we just discussed provide tumor antigen, which can then be available for recognition by the immune system. However, the immune environment at the liver is one that quiets the immune system, actively silencing the immune system. And so providing more antigen through these local regional therapies is not enough. It needs to be combined with immunotherapies in order to stoke an anti-tumor immune response.
So many of the immunotherapies that we use in the advanced space for HCC, which target some of our most common drug targets for immunotherapy across all cancers, including the PD-1, PD-L1 axis, as well as CTLA-4, and those drugs for the HCC space primarily being atezolizumab, pembrolizumab, nivolumab, durvalumab, targeting PD-1 or PD-L1, and tremelimumab or ipilimumab, targeting CTLA-4. We're learning that if we bring those agents earlier into the intermediate space and combine these with some of the local regional therapies that Dr. Newton was just discussing, we might have an opportunity to improve outcomes for patients. There have been some preliminary retrospective and real-world trials that have been done. First, looking at the idea of, is systemic therapy versus local regional therapy the right strategy on our intermediate stage patients? Those studies, as you can see here, do show that there probably is some role for both of these strategies in the intermediate space. And you can see here that some of these studies are shown on this schematic here. So the ABC-HCC trial, which is the combination of atezo-bev versus TACE in intermediate HCC, the LOST-B study, local regional versus systemic therapy in patients with BCLC stage B, and the REPLACE study, regorafenib plus pembrolizumab versus TACE-TER in intermediate stage HCC. So these are some prospective studies, again, trying to address this question of immunotherapy versus local regional therapy in the intermediate space.
So the rationale for looking into combining regimens of immunotherapy with local regional therapy is a potential synergy between these therapies. As it is, the response rate for immunotherapies is only 20 to 30% of patients. And even so, these are, a huge advancement in how we treat liver cancer, but we can do better. So we know that local regional therapy impacts the tumor microenvironment in a way that might make immunotherapy response rates higher and more durable by improving immune recognition, antigen presentation, and also by making the immune cells respond more to the cancer cells. We know from preclinical data and early clinical data that these therapies have complementary actions on the cancer immunity cycle, acting at different points on this cycle. And there are many trials in progress investigating the utility of these combinations and also investigating their safety and feasibility.
So as Dr. Newton described, there's a strong biological rationale for combining immunotherapy with local regional therapy in patients with intermediate stage HCC. And you can see here that there are a number of large landmark studies that are either ongoing or have had early readouts, including Emerald-1, looking at the combination of durvalumab plus or minus bevacizumab, in combination with TACE versus TACE alone, or other combinations, as you can see listed on this slide. I'd like to take this opportunity to walk us through a little bit of the Emerald-1 data, which has been the most mature to date. Emerald-1 is a global phase 3 study investigating the combination of TACE with immune checkpoint blockade plus or minus VEGF inhibition. And you can see here that the study population for the Emerald-1 study is adults with HCC, not amenable to curative therapy, no extrahepatic disease, with good liver function, Child-Pugh A to B7, good performance status, measurable disease, excluding high-level portal venous invasion, and patients that have not received prior systemic therapy or TACE. And there were two portions to this study. There was a TACE portion followed by a systemic therapy portion. And you can see that patients were randomized to one of three arms. Arm A was durvalumab plus TACE versus durvalumab plus TACE versus placebo plus TACE. And patients at Arm A went on to receive durvalumab plus placebo for bevacizumab. Patients in Arm B went on to receive durvalumab plus bevacizumab. And patients in Arm C went on to receive placebo plus placebo. Although this data is still being collected, early readout for the key primary and secondary endpoints, which were progression-free survival, you can see that the combination of durvalumab and bevacizumab plus TACE versus those patients treated with TACE alone had a median PFS of 15.0 months versus 8.2 months, with a hazard ratio of 0.77. Not surprisingly, those patients that received durva-bev plus TACE also had the highest objective response rate of 43.6% and the longest time to progression of 22 months. Importantly, these agents, both the interventional agent with TACE as well as durvalumab and bevacizumab, are well-characterized therapies in the HCC space, and this study identified no new key safety signals. And we're still waiting for ongoing data collection with this study, most importantly looking at the potential for improvement in overall survival.
So the Emerald-1 data is certainly very encouraging, but many places, especially in North America, have gravitated towards using Y90 radioembolization more and more. So there are pushes to evaluate the utility and the efficacy of combining TARE with immunotherapy. This is a phase 1/2A pilot of Y90 with durvalumab. It's a small phase 1/2A study with 24 patients who are BCLC B or C and have no extrahepatic disease. And they're starting on durvalumab 1 to 2 weeks after undergoing Y90 radioembolization and then receiving doses every 4 weeks thereafter. The outcomes thus far is, as you can see on the slide. But all of this data is very early, and we're in the early stages of collecting these data of combined therapies. But we are hopeful that these studies will help guide us in our multidisciplinary tumor boards for how to select the correct patients who would be amenable to combined therapies and to apply them to those patients. In addition, there are other trials of immunotherapy combined with radioembolization. There's Rowan and Emerald Y90 and that are expected to be completed in 2027 and 2026, respectively.
Returning to our case study for Ms. Rhodes, she's our 53-year-old female with history of obesity, controlled hypertension, treated dyslipidemia and prediabetes, presented to the ED with severe right upper quadrant abdominal pain. On MRI, she was found to have an 11 centimeter mass, predominantly in the right lobe. Her biopsy confirmed that she has MAFLD without cirrhosis, Child-Pugh A score with good functional status. In considering treatment options for our patient, Ms. Rhodes, we'll need to consider her liver function, the stage of cancer, and best treatment options. Dr. Newton, what type of local regional therapies might we consider for this patient?
Thank you, Megan. So with this patient, first of all, we'd have to make absolutely certain that she is not a candidate for surgery, and that really depends on how extensive the disease is, has predominantly in the right lobe. But let's say that she's not a surgical candidate. In the past, she would have been a candidate primarily for TACE, for chemoembolization, but that's a really large mass, and it's very hard to get a mass like that to shrink down with TACE alone. You quickly exhaust the amount of embolic that you apply. Increasingly, for these large masses, we've been applying Y90 radioembolization, where we can get very high doses of radiation into the mass and cause significant shrinkage, sometimes downstaging the patient for either surgical excision or even in some cases they could undergo ablation. So those would be the local regional therapies that we would discuss in our tumor board.
And Dr. Burgoyne, would we consider systemic therapy for Ms. Rhodes?
It's a great question, Megan, and as Dr. Newton alluded to, we have really advanced quite significantly in the local regional therapies that we have to offer patients. So I know that I can always trust my interventional radiology colleagues to be open and honest about whether or not their tools will be efficacious. And in a patient like this, even with a large liver mass, as long as it's not invading into the vasculature in a significant way, if they feel like they can get good tumor control with tear, that's typically what we would consider at our tumor board as well. For those patients that progressed through Y90 or developed additional bilobar disease or, of course, developed extrahepatic disease despite their tear, then we would typically consider those patients for systemic therapy. But I think this patient would be best served by at least a crack at local regional therapy to see if we could get good disease control.
Excellent. So for Ms. Rhodes, we'd want to ensure shared decision making with our patient. As a nurse, I would want to, dial in, know her support systems. If she has support of a family member, a spouse, neighbors, or friends. Ensure that she's well educated, both in person, but also to have it in writing, any potential signs and symptoms that could be urgent or those that, could be fielded to the nurse. And also make sure she has contact information for the clinic and those that she can reach out to and trust if in need.
I think we should always consider our patients for clinical trials as well. So as Dr. Newton noted, there's a strong interest in this intermediate stage space for HCC in the combination for immunotherapy and local regional therapy. So any available protocols that we had combining either TACE with immunotherapy or TARE with immunotherapy would be desirable, or connecting our patients with other centers close by that might have clinical trials. This woman is young, she has good liver function, and we know that patients on clinical trials often have the best outcomes.
Our key takeaways from today include the currently available therapies for intermediate stage HCC to be used to control the disease, palliate, or downstage disease to surgery or transplant. Catheter-directed therapies such as TACE and TARE continue to comprise the mainstay of treatment for intermediate stage HCCs. Cures after catheter-directed therapies for the intermediate stage HCC remain uncommon, and downstaging to the curative therapy for transplant, resection, or ablation remains the goal. As we've discussed, emerging evidence suggests synergistic effect of combining TACE or TARE with our immunotherapies, with ongoing clinical trials examining the safety and efficacy of these combinations for patients in the intermediate stage of disease.
Well, let's discuss systemic immunotherapy in the management of advanced HCC. and we have a few learning objectives for today. We are going to, hopefully by the end of this content module, be able to compare and contrast clinical profiles of immunotherapies for the treatment of advanced stage HCC, and be able to formulate a plan that considers patient-reported outcomes such as physical functioning, symptom burden, psychological well-being, and social functioning.
Great. So let's start with patient case Mr. Short. He's a 67-year-old man with obesity and cirrhosis thought to be secondary to metabolic syndrome and alcohol use. He has a multiphasic CT of the abdomen, which shows a 7-centimeter right-sided mass. There's arterial phase hyperenhancement and washout, and invasion into the right portal vein. There's also a 4-centimeter periportal lymph node. His labs show a bilirubin of 0.9, albumin of 3.5, and INR of 1.0. Platelets are 102,000, and the AFP is elevated at 327, and he has a good ECOG performance status of 1. So let's review the treatment recommendations from the BCLC guidelines. So because this patient has portal vein invasion with a lymph node, which is outside of the liver, of course, he falls into the category of advanced stage or BCLCC. On the left, we have BCLCA, which is the early stage patients where we think about resection, transplant, potentially ablation. Then there's the intermediate stage B, where patients are often referred for local regional therapy. And then to the right is the BCLC-D patients where, because of either a poor performance status or poor liver function, we think about focusing on best supportive care or palliative care. So for this discussion, we're going to be thinking about treatment options for the advanced stage or BCLC-C population. And if we look at the NCCN guidelines, when we think about first-line systemic therapy, the preferred regimens that we'll be discussing today are the combination of atezolizumab and bevacizumab and the combination of tremelimumab and durvalumab.
Well, let's talk a little bit about the landmark phase 3 clinical trials that led to the approval of these regimens. So these are going to be, namely, IMbrave 150, which was a randomized phase 3 open-label study comparing atezolizumab plus bevacizumab versus sorafenib, and Himalaya, which was a phase 3 randomized open-label study looking at the STRIDE regimen, tremelimumab and durvalumab, versus durvalumab monotherapy versus sorafenib. So let's start a discussion looking at these patient populations. So as you can see, the patient populations between these studies were relatively similar. All patients had to have advanced HCC. Patients needed to be treatment naive with no prior systemic therapy treatment. Patients needed to have good liver function, Child-Pugh, good performance status, less than or equal to 1 by ECOG. However, there were a few key differences in that the Himalaya patient population, patients that had main portal vein thrombosis were excluded, and also EGD was not required, which was required for assessment of esophageal varices in the bevacizumab study of IMbrave 150. Endpoints, as you can see, for IMbrave 150, co-primary endpoints of overall survival and progression-free survival, key secondary endpoints of response. And then the primary endpoint for Himalaya was overall survival, STRIDE versus sorafenib, with other secondary endpoints such as durvalumab versus sorafenib, assessed for survival, progression-free survival, response, and duration of response. And if we look at this top-line data from these studies, you can see obviously that both of these were positive studies that led to these becoming new standard of care treatments for our patients. And the median overall survival for atezolizumab plus bevacizumab in comparison to sorafenib in the IMbrave 150 study was 19.2 months versus 13.4 months with sorafenib. If we switch gears a bit to the Himalaya study, again, just looking at our primary endpoint of STRIDE versus sorafenib, a median overall survival for patients treated with STRIDE of 16.4 months versus 13.8 months with sorafenib. And you can see other key efficacy and safety outcomes also listed on this slide. Objective response rates of about 30% with atezo-bev, objective response rates of about 20% with STRIDE. And then in terms of bleeding events, which is something that we always worry about in our HCC patient population, relatively acceptable rates of bleeding after patients were assessed by endoscopy for the atezolizumab patients, and low rates of bleeding in the Himalaya population. In addition to the exciting efficacy signals that we see with immunotherapy, we always do need to be, of course, mindful of the safety signals. And fortunately, at this point, both bevacizumab as well as immune checkpoint inhibitors have fairly well characterized safety signals, and we did not learn any unexpected signals from either IMBRAVE 150 or Himalaya. But when we're thinking about VEGF-targeted therapies, we do know that we need to be mindful of that toxicity profile, bleeding, hypertension, proteinuria, and then, of course, for anyone that's treated with an immune checkpoint inhibitor, being mindful of the risk for immune-related adverse events, which we're going to talk about a little bit later. So we can talk about the extension of the Himalaya data. We have this longer-term cutoff looking at patients 4 years out, which is really a time that we would have thought that our patients would make it to just a short 5 or 10 years ago. So immunotherapy really has transformed the landscape of how we think about HCC patient care. And we can see that these tails of these curves for patients treated with STRIDE in comparison to sorafenib, with 25% of patients alive even at 4 years treated with the STRIDE regimen.
And I think importantly, patient-reported outcomes were collected on both of these studies. And these pre-planned analyses showed that there really was a benefit in giving immune therapy over sorafenib in terms of their quality of life, their functioning, and their symptom burden. So not only did patients have longer survival, but they also had an improvement in their quality of life. And when we think about, other patient groups, because we know that most of the patients that we treat in clinic may not have fit all of the inclusion criteria of the 2 studies we just discussed, but there is some real world data that looks at patients who have maybe liver function that would have been outside of these trials. So we think often about the patients with B7 or B8 disease, which is many of the patients that we see. And so there are prospective studies that are collecting data with both the atezo-bev regimen and the STRIDE regimen in this patient population that often reflects the real world patients that we see.
So let's get things back to our patient. So as we're thinking about the best treatment regimen for Mr. Short, we need to do a little bit more workup. So as we just discussed, assessing for the presence of esophageal varices is always very important in our patients with HCC. So Mr. Short underwent a pre-treatment EGD, which did identify that he had clinically significant esophageal varices that required banding. And after discussion with hepatology, the decision was made that the bleeding risk was probably too high to use either bevacizumab or for him to be eligible for clinical trials. Therefore, he was offered first-line systemic therapy with STRIDE. And we want to think about how this is going to be feasible for Mr. Short. So I'm going to ask Megan to comment maybe on how we can assess him best for supporting him through this treatment.
Sure. So for a patient like Mr. Short, we'd want to ensure he has, transportation to make it to and from his appointments, to stay on track with his treatment regimen, try to ensure his success. And for that support includes, support people, whether that be a significant other, children, friends, neighbors. Transportation-wise, does he take public transportation? Are there financial burdens with that transportation as well, connecting the patient to resources that they may need.
Great. So we get Mr. Short connected and set up so he has everything that he needs to be adherent to his treatment. And then we start him on STRIDE and get him through 2 cycles of therapy, which is usually when we would think after 2 months of treatment about getting some reassessment, if we want to get kind of an early information about how well the treatment is working. And Stacy, what do we see?
Yeah, so fortunately, this patient has had a partial response with 35% reduction in the size of his primary tumor, and there is decreased enhancement in the right portal vein. So we have a positive sign to stay on track with this treatment. And when we bring him in to discuss the scan and see how he's doing for the next cycle, we find out that he's been having diarrhea, which he was having some initially, and we started over-the-counter medication that was controlling things. But now at the next visit, we see that this has really progressed to 7 to 10 bowel movements a day, which is pretty significant. So, Megan, how do we, help patients know when to call us and make sure that they and their family are educated on what would be concerning, to us to let us know as soon as possible when these symptoms start?
Sure. I think, first and foremost is having, this information written down for the patients, because there's a lot of conversation, a lot going on between nurses and doctors and family members about their care. So definitely having, those symptoms, the red flag warnings where they'll want to, either notify their nurse or seek urgent care. Also making sure they have a direct line of contact, the lifeline, to someone that they've met, someone that they trust. And then when they do call, assessing, the severity of the symptoms, weeding out, are these something that needs urgent medical attention, directing them to the emergency room, and also reiterating, should those symptoms progress, to come in for urgent care. But then, once it, decided that it's not urgent, that we would trial a new medication, something to help better with their symptom management, ensuring that, they are able to get that prescribed medication and understand how to take it and when to take it and for how long.
So let's think about how we manage immunotherapy, toxicities. And again, right, of course, one of the most important things is the education, as Megan just pointed out, to make sure that patients are able to identify the signs early and contact us so that we could act soon. I always tell patients, don't wait till the next appointment to come in and tell me that you had a miserable week. I want to know about it the day that it starts. And of course, we think about whether we need to give more supportive care, or potentially, if it's autoimmune adverse events with immune therapy, we think about when to start steroids. And typically for a grade 3 diarrhea in this situation, we would discuss starting steroids in this patient.
So I think that we've hopefully learned a lot about today's case from Mr. Short, who I think is a really good representative patient based on what we see in our clinic. And it's always important that we're thinking about the whole patient, their liver function, their performance status, their support system, as we're selecting the most appropriate frontline systemic therapy regimen. And we have this very exciting data showing that we have really good outcomes for many of our patients, particularly those that respond well to immunotherapy, some of whom are now living up to 4 years on treatment. And as long as we can balance that efficacy signal that we're seeing with people that are responding really well and doing well with the toxicities, because we do see these immune-related adverse events with immunotherapies. A lot of the time we are able to support people through those with supportive care, or sometimes people requiring steroids. And then really most importantly, making sure that we are identifying and overcoming any potential barriers to care, supporting their patients through their treatment.
Welcome. We'll now be discussing systemic immunotherapy and the management of advanced biliary tract cancers. Our learning objectives for this segment are to compare and contrast the clinical profiles of immunotherapies for the treatment of advanced stage biliary tract cancer, and to think about formulating a plan that considers the patient-reported outcomes such as physical functioning, symptom burden, psychological well-being, and social functioning.
Well, let's start by talking through a case to exemplify these patients with biliary tract cancer that we see and how we think about their best management strategies. So this is Ms. Golden. She's a 63-year-old woman who presented with malaise, tea-colored urine, and light-colored stools. And she ended up having some follow-up workup that included abdominal imaging, and that revealed a 3-centimeter obstructive mass in the hepatic hilum. Thankfully, she was evaluated by the surgical oncology team. She was deemed to be a good candidate for resection of curative intent, which was pursued. She received capecitabine for 6 months as adjuvant therapy, and she was being followed closely by her medical oncology team in follow-up with surveillance imaging. And for the first 3 years, she thankfully had no evidence of disease recurrence, but unfortunately then developed some symptoms of abdominal bloating. Urgent CT scans were done, which noted the development of ascites. There was some evidence of peritoneal nodularity on those scans. Those peritoneal nodules underwent imaging-guided biopsy, which unfortunately confirmed the recurrence of metastatic cholangiocarcinoma. And as part of our standard workup for all biliary tract cancer patients, molecular profiling of her tumor tissue was requested to help guide her therapeutic options. So let's talk a little bit about how we think about such patients that present with biliary tract cancer or cholangiocarcinomas. And we really do think of these in terms of their anatomic distribution, which really guides the management options from a surgical perspective. And we want to make sure that we are assessing patients to make sure that we are determining their candidacy for surgical resection or those that would be better served by palliative therapies. And when we think about these anatomic subtypes, it really depends on where the mass is originating. So for cases of patients that have their tumors arising within the liver parenchyma itself, we consider those patients to have intrahepatic cholangiocarcinoma, and those patients that have masses at the hilum, perihilar, and then those patients that have masses more distally in the biliary tree, distal cholangiocarcinoma. And you can see here the epidemiology of these tumors. This is a rare tumor type based upon the 5-year overall survival statistics shown here as well. Still a lot of opportunity for improvement here. This is a disease that is a bit difficult to treat, high rates of recurrence after resection, and we are making some headway in our systemic therapies that we have available with the development of combo therapies that we're going to talk about today, adding chemotherapy and immunotherapy together, as well as assessing people for molecular drivers that have targeted therapies available.
So when we look at the NCCN guidelines for systemic therapy for unresectable and metastatic biliary tract cancer, the preferred regimens for first-line therapy is the combination of gemcitabine and cisplatin with either durvalumab or pembrolizumab, which durvalumab is an anti-PD-L1 antibody and pembrolizumab is an anti-PD-1 antibody. And these are for patients who are candidates for immune therapy. So let's look in more detail at the TOPAZ-1 and KEYNOTE-966 trial descriptions. So the TOPAZ-1 study looked at the combination of gemcitabine, cisplatin, and durvalumab, and the KEYNOTE-966 study looked at the combination of cisplatin, gemcitabine with pembrolizumab. The treatment populations were similar in that they were unresectable, metastatic, or recurrent disease with good performance status. And the patients received either the chemotherapy plus the immunotherapy drug or the chemotherapy plus placebo. And then after 8 cycles, the patients received in the TOPAZ study durvalumab alone as the maintenance treatment to progression or the placebo. And in the KEYNOTE study, the maintenance therapy was pembrolizumab plus gemcitabine or the placebo with gemcitabine for up to 35 cycles. The primary endpoints of both studies were overall survival with multiple secondary endpoints, as you can see. And looking at some of the key efficacy data from the studies, you can see that both studies showed a median overall survival improvement that was statistically significant. So the overall survival was 11.5 months in the TOPAZ study with chemotherapy alone compared to 12.8. And in the KEYNOTE study, chemotherapy median overall survival was 10.9 months versus 12.7 in the combination. The overall response rates were 19% for chemotherapy alone in the TOPAZ study, 27% for the combination, and 29% in both arms for the KEYNOTE study. There were some patients who had to discontinue due to treatment-related adverse events. that was not very different between the arms, and there were some immune-mediated adverse events on both studies. When we look at the 3-year data, we see in the TOPAZ study that there was still a significant separation of the curves even out at 3 years. And this is often what we see in studies with a combination of chemotherapy and immunotherapy, that the median overall survival does not tell the whole story, and it is useful to look at the tail of the curve to see what happens further out past the median survival. So you can see here that at 36 months, the overall survival rate more than doubled from 6.9% to 14.6%. And then we also have 3-year data from the Keynote 966 study, which shows a smaller separation of the curves. It's important to look at patient-reported outcomes in these studies. Both studies had patients report on several different instruments. And the good news is that there was no decrement in quality of life for the patients that received immunotherapy over the patients that received chemotherapy and placebo. So even though we know that there could be significant related adverse events from immunotherapy, between patient education and management, the patients did not report that there was a decrease in their quality of life.
So let's loop back to our patient case. So Ms. Golden was recommended palliative systemic therapy based upon the data that we just reviewed for TOPAZ 1 and Keynote 966. And that therapy that was recommended for her was the combination of gemcitabine and cisplatin with the addition of durvalumab. So it's always important when we're thinking about any type of systemic therapy for our patients, including chemotherapy and immunotherapy, that our patients are informed of expectations and what to expect in terms of their treatment and the side effects. And I think this is a good example on how we need to use shared decision making to make sure patients feel well supported. So Megan, how would you help support a patient like Ms. Golden that we're thinking about this combination of chemotherapy plus immunotherapy?
Sure. For patients, Ms. Golden want to ensure, as you said, continued shared decision making throughout the care that she receives. This includes, ongoing conversations of goals of care with her, and reassessing quality of life throughout. In addition to understanding her support systems, whether that be family, spouse, close friends, neighbors, transportation to and from hospital visits, multiple appointments throughout several months, and if there's financial burdens related to transportation, connecting to social work or transportation resources. With these patients too, a little bit of additional education goes a long way, making sure both verbal education and printed are given, especially with risks for infection, with bile obstruction, and potential to become septic, ensuring that they know those red flag warning signs and symptoms for themselves, when to seek urgent care, and let their providers and their care team really know in real time when they're experiencing symptoms. Also, nutrition is important, so ensuring if they could benefit from dietitian consults, that we have that on board, and also behavioral health or mental health, to make sure that they have that support as well.
Yeah, we always want to make sure that we're thinking about the whole person, and after that in-depth discussion with the patient and their family and their caregivers, Ms. Golden elected to proceed with the combination of chemotherapy plus durvalumab. And thankfully, after 2 months of treatment, we got some restaging scans which showed that the nodules in the peritoneum were starting to decrease in size, and then those symptoms of abdominal bloating and distension that she had from her malignant ascites were starting to improve, correlating with that objective response we were seeing on imaging. So typically for a patient like Ms. Golden, we would treat until our maximal response over 6 months, in accordance with the way that the studies were done for both Topaz 1 and Keynote 966. And then if Ms. Golden's doing well after those 6 months or 8 cycles of the combination of chemotherapy and immunotherapy, thinking about de-escalating to a maintenance strategy, which with the Topaz 1 regimen would be durvalumab monotherapy given just once a month, which decreases the number of visits and decreases obviously the toxicity related to the chemotherapy if we're omitting those agents. And I think it's important here, as we're hopefully letting Ms. Golden cruise for a while on immunotherapy, that we start to think a bit more carefully about what her molecular options might be in the event that she would progress in the future. So one important fact that we have learned about the management of biliary tract cancer patients is that the prevalence of targetable driver mutations is quite high, up to 50% in some studies, particularly for those with intrahepatic cholangiocarcinoma. And you can see here this list of targets, as adapted from the NCCN guidelines, shows that we can see a variety of things, both tumor agnostic findings that we can see in multiple tumor types, such as NTRK gene fusions or microsatellite instability. However, there are some specific targets that we see frequently in our biliary tract cancer patients that have important targets. Those are things like FGFR2 fusions or rearrangements, IDH1 mutations, and then we can also see a number of other less common mutations as shown in this table. And it's really important that all patients really at diagnosis are offered a comprehensive panel for molecular profiling. So for those patients that we have identifiable targets, we think about what therapies are best matched to those. And again, here's a snapshot of the NCCN guidelines showing some of those FDA-approved agents, either in a tumor agnostic fashion or specifically for patients harboring these alterations with biliary tract cancers that are shown here. So those are things like NTRK inhibitors, immunotherapies for those patients that are mismatch repair deficient or microsatellite unstable or have high tumor mutational burden, and then other things like RET fusions, HER2 amplification, and then again, most importantly and specific to this disease, patients that have FGFR2 fusions or IDH1 mutations. Biliary tract cancer is a rare tumor type. There is a lot of ongoing research in this space, particularly as we are learning more about the molecular drivers, as we're learning more about the immunotherapy signals that we've seen in both the Topaz 1 and Keynote 966 studies. And this is just a partial list of ongoing research in this area.
And so to think about some key takeaways from this discussion, it is now standard of care for patients to receive immunotherapy in addition to their chemotherapy for those patients who don't have any contraindication to immunotherapy. I want to stress the importance of molecular profiling for all patients with biliary tract cancers. You can't know that they have these mutations until you do the testing, and it could really impact their future treatment options. And then, of course, we really want to think about identifying to overcome potential barriers to care and support patients and their families throughout their treatment.
In providing supportive care for our patients, we'll want to make sure to connect them to resources and help them identify, barriers ahead of the game. Early connections with services like palliative care, also making sure they're aware of the availability of home health nursing, people to help out in the home and their caregivers and, their own support group. In addition to those in-house with us, as far as dietitians and social work, we want to make sure that they have information to contact their healthcare team, whether it be an RN coordinator and their physicians, nurse practitioner, APPs, that they have a direct line of communication to keep the team aware of any needs that might come up.
Welcome. Today we will be speaking about the principles of multidisciplinary care in hepatocellular carcinoma and biliary tract cancer. The learning objective of our program is to develop strategies for effective multidisciplinary communication and coordination. As some of you may know, the primary goals of multidisciplinary care in HCC and biliary tract management are to facilitate communication between different specialists, to help provide individualized care, and to optimize diagnosis, treatment, and outcomes for our patients with primary liver cancer. Now, multidisciplinary care and multidisciplinary teams is often used as a basket term, but there are actually several models of multidisciplinary care for liver cancer, including multidisciplinary tumor boards, fluid referral systems between specialists, and co-located clinics with multiple specialists that are present concurrently.
Who is involved in HCC multidisciplinary care? Institutions may not have all providers and teams in one facility. Standardizing operational pathways for interventions, including chemotherapy, can improve care quality and consistency across facilities. Partnerships with other institutions can provide essential services such as specialized gastrointestinal support, interinstitutional liver cancer clinics, external liver tumor boards, and transplant services. Operational components of these multidisciplinary teams for HCC would include regular meetings with the multidisciplinary team participants. They should meet regularly to review cases and make treatment decisions. Standardized forms would help in standardizing the care provided to the clients. A one-page form to record relevant facts and consensus recommendations during those regular meetings. Summary documentation after meetings would be a summary statement entered in the patient's electronic health record and a letter sent to the referring physician to include everyone be on the same page and also help in guiding the patient with their shared decision making. Continuous improvement within the multidisciplinary team should occur regularly, including a review and update and protocols based on emerging evidence and ongoing clinical trials. And this should also include personal experiences within your team as certain situations arrive with various clients.
In regards to documentation, these are some specific examples from the ASLD Quality Measures Committee. So staging should be clearly defined, specifically tumor burden, liver functions, and especially performance status at the time of diagnosis, given that many of our patients with liver cancer have underlying cirrhosis. Treatment should also be clearly delineated, specifically if curative intent is feasible, and this includes liver transplant candidacy as well as the multidisciplinary tumor board recommendations. And in cases of more advanced disease, advanced care planning for patients with BCLC C or D. Regarding reported benefits of multidisciplinary teams in liver cancer care, we know that MDTs are associated with recommendations for guideline concordant treatment. We also know that MDTs lead to higher rates of curative treatment receipt, as well as significantly improvement in overall survival rates.
There's also other potential advantages of MDT implementation. Multifactorial advantages include enhanced treatment discussion. When we get everyone in the same room, it's much better than sending messages through the electronic chart. More perspectives on imaging and biopsy results, so it's so important to have radiology and pathology in the conference with us, and increased center-wide awareness of HCC, possibly leading to earlier detection. In addition, MDTs may become more important as treatment options and combinations increase, so there's a greater need for communication between providers, and it's a good setting to facilitate recruitment to studies on optimal care paths and combined treatments. The key takeaways from principles of multidisciplinary care in HCC and BTC is there are many effective approaches to forming multidisciplinary teams, including co-located clinics, multidisciplinary tumor boards, and regional multidisciplinary groups that meet virtually. MDTs are associated with better outcomes for our patients with HCC and BTC, and MDTs are likely to become even more important in the future as we continue to have advances in care for our HCC and BTC patients.